Angina pectoris, the primary symptom of ischemic heart disease, is caused by transient episodes of myocardial ischemia that are due to an imbalance in the myocardial oxygen supply-demand relationship. This imbalance may be caused by an increase in myocardial oxygen demand, decrease in myocardial supply, or both. Because blood flow is inversely proportional to the artery's luminal radius, the progressive decrease in vessel radius in coronary arteriosclerosis can impair coronary blood flow and lead to symptoms of angina when oxygen demand increases as with exertion. Regardless of the precipitating factors, the sensation of angina is similar in most patients. Good day. This is Dr. Alson Cabardes, and we are going to discuss about vasodilators and anti-anginal medications. Vasodilators are used to treat hypertension, heart failure, and angina. There are different types of vasodilators. Some vasodilators act primarily on resistance vessels or called arterial dilators. Venous dilators are very effective, on the other hand, for angina and sometimes used for heart failure, but are not used as primary therapy for hypertension. But most vasodilator drugs are mixed or balanced vasodilators in that they dilate both arteries and veins and therefore can have wide application in hypertension, heart failure, and angina. Arterial dilators reduce arterial pressure by decreasing systemic vascular resistance. It benefits patients in heart failure by reducing the afterload on the left ventricle, which enhances stroke volume and cardiac output and leads to secondary decrease in ventricular preload and venous pressures. Anginal patients benefit from arterial dilators because by reducing afterload on the heart, vasodilators decrease the oxygen demand of the heart and thereby improve the oxygen supply-demand ratio. An example of an arterial dilator is hydralazine. It is highly selective for arterial resistance vessels. Selective arterial dilation decreases systemic vascular resistance. As you can see on the figure on the right, it increases the slope of the systemic vascular function curve, as shown by the red line, without appreciably changing the x-intercept or the mean circulatory filling pressure. This alone causes the operating point to shift from A to B, resulting in an increase in cardiac output with a small increase in right atrial pressure. The reason for the increase in the right atrial pressure is that the arterial dilation increases blood flow from the arterial vasculature into the venous vasculature, thereby increasing venous volume and pressure. Arterial dilators, however, also reduce afterload on the ventricle and therefore unload the heart, which enhances the pumping ability of it. Adding to this afterload effect is the influence of enhanced sympathetic stimulation due to baroreceptor reflex in response to the fall in arterial pressure, which increases heart rate and inotropy. Because of these compensatory cardiac responses, arterial dilators increase cardiac output with little or no change in right atrial pressure. Although cardiac output is increased, systemic vascular resistance is reduced relatively more, causing arterial pressure to fall. The effect of reducing afterload on enhancing cardiac output is even greater in failing hearts because stroke volume more sensitive to the influence of elevated afterload in hearts with impaired contractility. Venous dilators. Drugs that dilate venous capacitance vessels serve two primary functions in treating cardiovascular disorders. Venous dilators reduce venous pressure, which reduces preload on the heart, thereby decreasing cardiac output. This is helpful in angina because it decreases the oxygen demand of the heart and thereby increases the oxygen supply-demand ratio. Oxygen demand is reduced because decreasing preload leads to a reduction in ventricular wall stress by decreasing the size of the heart. Reducing venous pressure decreases proximal capillary hydrostatic pressure, which reduces capillary fluid filtration and edema formation. Therefore, Venous dilators are sometimes used in the treatment of heart failure along with other drugs because they help to reduce pulmonary and/or systemic edema that results from the heart failure. Venous dilation increases venous compliance by relaxing the venous smooth muscle. As you refer on the figure on the right, increased compliance causes a parallel shift to the left of the vascular function line, which decreases the mean circulatory filling pressure. This causes the operating point to shift from A to B, resulting in a decrease in cardiac output with a small decrease in the right atrial pressure. The reason for these changes is that venous dilation, by reducing the right atrial pressure, decreases right ventricular preload, which decreases stroke volume and cardiac output by the Frank-Starling mechanism. Reduced cardiac output causes a fall in the arterial pressure, which reduces afterload on the left ventricle and leads to baroreceptor reflex responses, both of which can shift the cardiac function curve up and to the left. Sympathetic activation can also lead to an increase in systemic vascular resistance. The cardiac effects or decreased cardiac output of venous dilation are more pronounced in normal hearts than in failing hearts because of where the hearts are operating on their Frank-Starling curves. The most important effects in terms of clinical utility for patients are the reduction of venous pressure and therefore cardiac preload, cardiac output, arterial pressure, myocardial oxygen demand, and capillary fluid filtration and tissue edema. Mixed or balanced dilators. As you look at the figure on the right, the red line represents a systemic function curve generated when there is both venous dilation and arterial dilation, where the mean circulatory filling pressure is decreased and the slope is increased. Point P represents the new operating point. Where the point lies depends on the relative degree of venous and arterial dilation. If there is more arterial dilation than venous dilation, then point B may be located slightly above point A, where the cardiac function curve intersects with the new vascular function curve. In summary, mixed or balanced dilators decrease systemic vascular resistance and arterial pressure with relatively little change in right atrial pressure and cardiac output. Here's the classification of vasodilator drugs based on their primary mechanism of action. Alpha adrenoceptor antagonists, or alpha blockers. These medications block the effect of sympathetic nerves on blood vessels by binding on the alpha adrenoceptors located on the vascular smooth muscle. Most of these drugs act as competitive antagonists to the binding of norepinephrine that is released by sympathetic nerves synapsing on smooth muscles. These drugs are referred to as sympatholytics because they antagonize sympathetic activity. Some alpha blockers are non-competitive, like phenoxybenzamine, which greatly prolongs their action, whereas others are relatively selective for one type of alpha adrenoceptor. Alpha-1 adrenoceptor antagonists cause vasodilation by blocking the binding of norepinephrine to the smooth muscle receptors. Non-selective alpha-1 and alpha-2 adrenoceptor antagonists block post-junctional alpha-1 and alpha-2 adrenoceptors, which causes vasodilation. Alpha blockers dilate both arteries and veins because both vessel types are innervated by sympathetic adrenergic nerves. The vasodilator effect is more pronounced in the arterial resistance vessels. Because most blood vessels have some degree of sympathetic tone under basal conditions, these drugs are effective dilators. They are even more effective under conditions of elevated sympathetic activity, such as during stress and during pathologic increase. The most common side effects are related directly to alpha adrenoceptor blockade. This includes dizziness, orthostatic hypotension, due to loss of reflex vasoconstriction upon standing, nasal congestion due to dilation of nasal mucosal arterioles, headache, reflex tachycardia, especially with non-selective alpha blockers, and fluid retention. Here are some examples of alpha adrenoceptor antagonists. For the selective alpha-1 adrenoceptors, we have prazosin, terazosin, doxazosin, and trimazazine. For the non-selective antagonists, we have phentolamine and phenoxybenzamine. Angiotensin-converting enzyme, or ACE inhibitors. Though these drugs are considered antihypertensives, we will be discussing in this section the vasodilating capacity of these medications. ACE inhibitors produce vasodilation by inhibiting the formation of angiotensin II. This vasoconstrictor is formed by the proteolytic action of renin released by the kidneys acting on circulating angiotensinogen to form angiotensin I. Angiotensin I is then converted to angiotensin II by angiotensin-converting enzyme, or ACE. ACE also breaks down bradykinin, a vasodilator substance. Therefore, ACE inhibitors, by blocking the breakdown of bradykinin, increase bradykinin levels, which contribute to the vasodilator action of these medications. The increase in bradykinin is also believed to be responsible for a troublesome side effect of ACE inhibitors, namely dry cough. ACE inhibitors have the following actions. They dilate arteries and veins by blocking angiotensin II formation and inhibiting bradykinin metabolism. This vasodilation reduces arterial pressure, preload, and afterload on the heart. They also downregulate sympathetic adrenergic activity by blocking the facilitating effects of angiotensin II on sympathetic nerve release and reuptake of norepinephrine. They also promote renal excretion of sodium and water by blocking the effects of angiotensin II in the kidney and blocking angiotensin II stimulation of aldosterone secretion. This reduces blood volume, venous pressure, and arterial pressure. Lastly, they inhibit cardiac and vascular remodeling associated with chronic hypertension, heart failure, and myocardial infarction. Here are some ACE inhibitors. Note that each of the ACE inhibitors named above end with pril. Angiotensin receptor blockers, or ARBs. These drugs have very similar effects to angiotensin-converting enzyme inhibitors and are used for the same indications. Their mechanism of action, however, is very different from ACE inhibitors, which inhibit the formation of angiotensin II. ARBs are receptor antagonists that block type 1 angiotensin II receptors on blood vessels and other tissues such as the heart. These receptors are coupled to the GQ protein and IP3 signal retransduction pathway that stimulates vascular smooth muscle contraction. Because ARBs do not inhibit ACE, they do not cause an increase in bradykinin, which contributes to vasodilation produced by ACE inhibitors and some of the side effects of ACE inhibitors. ARBs have the following actions, which are very similar to ACE inhibitors. They dilate arteries and veins and thereby reduce arterial pressure and preload and afterload of the heart. They also downregulate sympathetic adrenergic activity. They promote renal excretion of sodium and water, and inhibit cardiac and vascular remodeling associated with chronic hypertension, heart failure, and myocardial infarction. Centrally acting sympatholytics. Sympatholytic drugs can block the sympathetic adrenergic system at three different levels. First, there's the peripheral sympatholytic drugs, such as the alpha adrenoceptor and beta adrenoceptor antagonists, which block the influence of norepinephrine at the effector organ, like the heart or blood vessel. Second, there are ganglionic blockers that block impulse transmission at the sympathetic ganglia. And lastly, There are drugs that block sympathetic activity within the brain. These are called centrally acting sympatholytics. Centrally acting sympatholytics block sympathetic activity by binding to and activating alpha-2 adrenoceptors. Several different centrally acting alpha-2 adrenoceptor agonists are available for clinical use. Side effects of centrally acting alpha-2 adrenoceptor agonists includes the following. Direct-acting vasodilators. The one drug in this group, hydralazine, does not fit neatly into the other mechanistic classes in part because its mechanism of action is not entirely clear and it appears to have multiple direct effects on the vascular smooth muscle. First, hydralazine causes smooth muscle hyperpolarization quite likely through the opening of the potassium channels. It also may inhibit IP3-induced release of calcium from the smooth muscle sarcoplasmic reticulum. This calcium combines with calmodulin to activate myosin light chain kinase, which induces contraction. Finally, hydralazine stimulates the formation of nitric oxide by the vascular endothelium, leading to cGMP-mediated vasodilation. Hydralazine is used occasionally, although rarely alone, in the treatment of arterial hypertension. It is not first-line therapy. Its relatively short half-life, which necessitates frequent dosing, and its precipitation of reflex tachycardia make it undesirable for treating chronic hypertension. However, it is used in treating acute hypertensive emergencies, secondary hypertension caused by preeclampsia, and pulmonary hypertension. It is often used in conjunction with a beta blocker and diuretic to attenuate the baroreceptor-mediated reflex tachycardia and renal sodium retention, respectively. Hydralazine has a role in the management of heart failure because of its ability to reduce afterload and thereby enhance stroke volume and ejection fraction. When used in heart failure, it is given along with a diuretic and often with a nitrodilator. The common side effects of hydralazine include headaches, flushing, and tachycardia. About 10% of those using it experience a lupus-like syndrome. Reflex cardiac stimulation can precipitate angina in patients with coronary artery disease. Endothelin receptor antagonists. Endothelin 1 is a 21 amino acid peptide that is produced by the vascular endothelium. It is a very potent vasoconstrictor that binds to smooth muscle endothelin receptors, of which there are two subtypes, ETA and ETB receptors. These receptors are coupled to a GQ protein and receptor activation leads to the formation of IP3, which causes the release of calcium by the sarcoplasmic reticulum and increased smooth muscle contraction and vasoconstriction. There are also ETB receptors located on the endothelium that stimulate the formation of nitric oxide, which produces vasodilation in the absence of smooth muscle ETA and ETB receptor activation. This receptor distribution helps to explain the phenomenon that endothelin-1 administration causes transient vasodilation and hypotension followed by prolonged vasoconstriction and hypertension. Endothelin-1 receptors in the heart are also linked to the GQ protein and IP3 signal transduction pathway. Therefore, endothelin-1 in the heart causes sarcoplasmic reticulum release of calcium, which increases contractility. Endothelin-1 also increases heart rate. Because of its powerful vasoconstrictor properties and its effects on intracellular calcium, endothelin-1 has been implicated in the pathogenesis of hypertension, coronary vasospasm, and heart failure. A number of studies suggest a role of endothelin-1 in pulmonary hypertension, as well as in systemic hypertension. Endothelin-1 has been shown to be released by the failing myocardium where it can contribute to cardiac calcium overload and hypertrophy. Bosentan, a non-selective endothelin receptor antagonist which blocks ETA and ETB receptors, is currently used in the treatment of pulmonary hypertension. Another drug also used for pulmonary hypertension is ambrisentan, which is a selective EPA receptor antagonist. Some of endothelin antagonist side effects are common to most vasodilators, namely headache, cutaneous flushing, and edema formation. This class of drug may cause birth defects and therefore is contraindicated in pregnancy. These drugs can also cause liver injury. Ganglionic blockers. These are medications that block impulse transmission at the sympathetic ganglia. Neurotransmission within the sympathetic and parasympathetic ganglia involves the release of acetylcholine from preganglionic efferent nerves, which binds to nicotinic receptors on the cell bodies of postganglionic efferent nerves. Ganglionic blockers inhibit autonomic activity by interfering with neurotransmission within autonomic ganglia. This reduces sympathetic outflow to the heart, thereby decreasing cardiac output by decreasing heart rate and contractility. Reduced sympathetic output to the vasculature decreases sympathetic vascular tone, which causes vasodilation, and reduced systemic vascular resistance, which decreases arterial pressure. Parasympathetic outflow is also reduced by ganglionic blockers. Ganglionic blockers are not used in the treatment of chronic hypertension in large part because of their side effects, and because there are numerous, more effective, and safer antihypertensive drugs that can be used. They are, however, occasionally used for hypertensive emergencies. Several different ganglionic blockers are available for clinical use. However, only trimethophan camicillate is very occasionally used in hypertensive emergencies or for producing controlled hypotension during surgery. Side effects of trimethophan include prolonged neuromuscular blockade and potentiation of neuromuscular blocking agents. It can produce excessive hypotension and impotence due to its sympatholytic effect, and constipation, urinary retention, dry mouth due to its parasympatholytic effect. It also stimulates histamine release. Cyclic AMP-dependent phosphodiesterase inhibitors, or PDE3 inhibitors. Intracellular concentrations of cyclic AMP play an important second messenger role in regulating cardiac muscle contraction. Activation of the sympathetic nervous system releases the neurotransmitter norepinephrine and increases circulating catecholamines. These catecholamines bind primarily to beta-1 adrenoceptors in the heart that are coupled to GS proteins. This activates adenylyl cyclase to form cyclic AMP from ATP. Increased cyclic AMP through its coupling with other intracellular messengers increases contractility or inotropy, heart rate chronotropy, and conduction velocity drumotropy. Cyclic AMP is broken down by an enzyme called cyclic AMP-dependent phosphodiesterase, or PDE. The isoform of this enzyme that is targeted by currently used clinical drugs is the type 3 form. Inhibition of this enzyme prevents cyclic AMP breakdown and thereby increases its intracellular concentration. This increases cardiac inotropy, chronotropy, and drumotropy. PDE3 inhibitors can be thought of as a backdoor approach to cardiac stimulation, whereas beta agonists go through the front door to produce the same cardiac effects. Cyclic AMP also plays an important role in regulating the contraction of vascular smooth muscle. Beta-2 adrenoceptor agonists such as epinephrine stimulate the GS protein and the formation of cyclic AMP. Unlike cardiac muscle, increased cyclic AMP in smooth muscle causes relaxation. The reason for this is that cyclic AMP normally inhibits myosin light chain kinase, the enzyme that is responsible for phosphorylating smooth muscle myosin and causing contraction. Like the heart, the cyclic AMP is broken down by the cyclic AMP-dependent PDE3. Therefore, inhibition of this enzyme increases intracellular AMP, which further inhibits myosin light chain kinase, thereby producing less contractile force, promoting relaxation. The cardiac and vascular effects of cyclic AMP-dependent PDE inhibitors cause cardiac stimulation, which increases cardiac output, and reduces systemic vascular resistance, which tends to lower arterial pressure. Because cardiac output increases and systemic vascular resistance decreases, the change in arterial pressure depends on the relative effects of the PDE inhibitor on the heart versus the vasculature. At normal therapeutic doses, PDE3 inhibitors such as milrinone have greater vascular than cardiac effects so that the arterial pressure is lowered in the presence of augmented cardiac output. Because of the dual cardiac and vascular effects of these compounds, they are sometimes referred to as inodilators. Cyclic GMP-dependent phosphodiesterase inhibitors or PDE5 inhibitors. There is a second isoenzyme form of the phosphodiesterase in vascular smooth muscle that is a cyclic GMP-dependent phosphodiesterase. The type 5 isoform of this enzyme, PDE5, is found in the corpus cavernosum of the penis and in vascular smooth muscle. This enzyme is responsible for breaking down cyclic GMP that forms in response to increased nitric oxide. Increased intracellular cyclic GMP inhibits calcium entry into the cell, thereby decreasing intracellular calcium concentrations and causing smooth muscle relaxation. Nitric oxide also activates potassium channels, which leads to hyperpolarization and relaxation. Finally, nitric oxide acting through cyclic GMP can stimulate a cyclic GMP-dependent protein kinase that activates myosin light chain phosphatase, the enzyme that dephosphorylates myosin light chains, which leads to relaxation. Therefore, inhibitors cyclic GMP-dependent phosphodiesterase by increasing intracellular cyclic GMP, enhance smooth muscle relaxation and vasodilation, and cause penile erection. The cardiostimulatory and vasodilatory actions of PDE3 inhibitors make them suitable for the treatment of heart failure. Arterial dilation reduces afterload on the failing ventricle and leads to an increase in stroke volume and ejection fraction, as well as increases organ perfusion. Reducing the afterload leads to a secondary decrease in preload on the heart that helps to improve the mechanical efficiency of dilated hearts and to reduce ventricular wall stress and oxygen demands placed on it. The cardiostimulatory effects of these drugs increases inotropy, which further enhances stroke volume and ejection fraction. Tachycardia, however, also results, and this is not beneficial. Therefore, doses are used that minimize the positive chronotropic actions of the drug. A baroreceptor reflex, which occurs in response to hypotension, may contribute to the tachycardia. The somewhat selective vasodilatory actions of PDE5 inhibitors have made these compounds very useful in the treatment of male erectile dysfunction. The PDE5 inhibitor sildenafil is also approved for the treatment of pulmonary hypertension. Several different PDE inhibitors are available for clinical use. The PDE3 inhibitors, except cilostazol, are used for treating acute decompensated heart failure, whereas PDE5 inhibitors are used for treating male erectile dysfunction and pulmonary hypertension. Note that the PDE3 inhibitors used in acute failure end in on, whereas the PDE5 inhibitors end in fil. The following are the side effects of the phosphodiesterase inhibitors. Potassium channel openers. These drugs activate or open ATP-sensitive potassium channels in vascular smooth muscle. Opening these channels hyperpolarizes the smooth muscle, which closes voltage-gated calcium channels and decreases intracellular calcium. With less calcium available to combine with calmodulin, there is less activation of myosin light chain kinase and phosphorylation of myosin light chains.
This leads to relaxation and vasodilation. Because small arteries and arterioles normally have a high degree of smooth muscle tone, these drugs are particularly effective in dilating these resistance vessels, decreasing systemic vascular resistance, and lowering arterial pressure. The fall in arterial pressure leads to reflex cardiac stimulation or the baroreceptor-mediated tachycardia. Being effective arterial dilators, potassium channel openers are used in the treatment of hypertension. Although these drugs are not first-line therapy for hypertension because of their side effects, and therefore they are relegated to treating refractory severe hypertension. They are generally used in conjunction with a beta blocker and diuretic to attenuate the reflex tachycardia and retention of sodium and fluid, respectively. Although several potassium channel openers have been used in research for many years, only minoxidil is approved for use in humans for treating hypertension. The common side effects of minoxidil include headaches, flushing, and reflex tachycardia. The potent vasodilator actions of minoxidil can lead to fluid retention and edema formation. Reflex cardiac stimulation can precipitate angina in patients with coronary artery disease. Minoxidil can produce T-wave changes in a high percentage of patients under chronic treatment. One of the most noted side effects of minoxidil is hypertrichosis, a thickening and enhanced pigmentation of body hair, and therefore this drug is more commonly used for treating baldness. Renin inhibitors. Renin inhibitors are one of four classes of compounds that affect the renin-angiotensin-aldosterone system, the other three being angiotensin-converting enzyme inhibitors, angiotensin receptor blockers, and aldosterone receptor antagonists. Renin inhibitors produce vasodilation by inhibiting the activity of renin, which is responsible for stimulating angiotensin II formation. Renin inhibitors have the following actions which are similar to those of the ACE inhibitors and ARBs. Aliskiren is a renin inhibitor that was approved for the treatment of hypertension by the US FDA in 2007. Aliskiren is an orally active non-peptide drug with a half-life of about 24 hours and is dosed once per day. Because of its relatively long half-life, it takes about 2 weeks of dosing to achieve a near maximal antihypertensive effect. It is metabolized by the liver and excreted by the kidneys. Normal therapeutic concentrations of aliskiren reduce plasma renin activity by 50 to 80%. It is effective as a monotherapy. When used in conjunction with thiazide diuretics or ARBs, the antihypertensive effects are additive. Aliskiren alone, like ACE inhibitors and ARBs, has a relatively low incidence of side effects and is well tolerated. Aliskiren has dose-related gastrointestinal adverse effects in some patients, diarrhea being observed in less than 3%. The incidence of cough is much lower in patients taking aliskiren than those taking ACE inhibitors. Angioedema can occur in patients taking aliskiren, although fewer than 1% of patients develop this condition. When administered with an ACE inhibitor, aliskiren can produce hyperkalemia, especially in diabetic patients. Recent studies, as in Altitude trial in 2011, have noted increased adverse events like non-fatal stroke, renal complications, hyperkalemia, and hypotension with no apparent additional benefits when added to treatment with ACE and ARBs in diabetic patients. As in ACE inhibitors, aliskiren should not be administered anytime during pregnancy, particularly in the second and third trimesters because of fetal and neonatal injury and risk of birth defects. Nitrodilators. Nitric oxide is a molecule produced by many cells in the body and has several important actions. In the cardiovascular system, nitric oxide is primarily produced by the vascular endothelial cells. This endothelial-derived nitric oxide has several important functions, including relaxing vascular smooth muscle, vasodilation, inhibiting platelet aggregation as an antithrombotic, and inhibiting leukocyte endothelial interactions, anti-inflammatory. These actions involve nitric oxide stimulated formation of cyclic GMP. Nitrodilators are drugs that mimic the actions of endogenous nitric oxide by releasing nitric oxide or forming nitric oxide within tissues. These drugs act directly on the vascular smooth muscle to cause relaxation and therefore serve as endothelial-independent vasodilators. There are two basic types of nitrodilators: those that release nitric oxide spontaneously, like the sodium nitroprusside, and organic nitrates that require an enzymatic process. Organic nitrates do not directly release nitric oxide. However, their nitrate groups interact with enzymes and intracellular sulfhydryl groups that reduce the nitrate groups to nitric oxide or to S-nitrosulfathiol, which then is reduced to nitric oxide. Nitric oxide activates smooth muscle-soluble guanylyl cyclase to form cyclic GMP. Increased intracellular cyclic GMP inhibits calcium entry into the cell, thereby decreasing intracellular calcium concentrations and causing smooth muscle relaxation. Nitric oxide activates potassium channels, which leads to hyperpolarization and relaxation. And finally, nitric oxide acting through cyclic GMP can stimulate a cyclic GMP-dependent protein kinase that activates myosin light chain phosphatase, the enzyme that desphosphorylates myosin light chains, which leads to relaxation. Although organic nitrates can dilate both arteries and veins, venous dilation predominates when these drugs are given at normal therapeutic doses. Venous dilation reduces venous pressure and decreases ventricular preload. This reduces ventricular wall stress and oxygen demand by the heart, thereby enhancing the oxygen supply-demand ratio. A reduction in preload also helps to improve subendocardial blood flow, which is often compromised in coronary artery disease. Mild coronary dilatation or reversal of coronary vasospasm will further enhance the oxygen supply-demand ratio and diminish the anginal pain. Coronary dilation occurs primarily in the large epicardial vessels, which diminishes the likelihood of coronary vascular steal. Systemic arterial dilation reduces afterload, which can enhance cardiac output while at the same time reducing ventricular wall stress and oxygen demand. At high concentrations, excessive systemic vasodilation may lead to hypotension and a baroreceptor reflex that produces tachycardia. When this occurs, the beneficial effects on the oxygen supply-demand ratio are partially offset. Furthermore, tachycardia by reducing the duration of diastole decreases the time available for coronary perfusion, most of which occurring during diastole. The primary pharmacologic action of nitrodilators, arterial and venous dilation, make these compounds useful in the treatment of hypertension, heart failure, angina, myocardial infarction. Another beneficial action of nitrodilators is their ability to inhibit platelet aggregation. Nitrodilators are not used to treat chronic primary and secondary hypertension. However, sodium nitroprusside and nitroglycerin are used to lower blood pressure in acute hypertensive emergencies that may result from a pheochromocytoma, renal artery stenosis, aortic dissection, and the likes. Nitrodilators may also be used during surgery to control arterial pressure within desired limits. Nitrodilators are used in acute heart failure and in severe chronic heart failure. Arterial dilation reduces afterload on the failing ventricle and leads to an increase in stroke volume and ejection fraction. Furthermore, the venous dilation reduces venous pressure, which helps to reduce edema. Reducing both afterload and preload on the heart also helps to improve the mechanical efficiency of dilated hearts and to reduce wall stress and the oxygen demand placed on the failing heart. Organic nitrates are used extensively to treat angina and myocardial infarction. They are useful in Prince Metal's variant angina because they improve coronary blood flow by reversing and inhibiting coronary vasospasm. They are also important in other forms of angina because they reduce preload on the heart by producing venous dilation, which decreases myocardial oxygen demand. Several different nitrodilators are available for clinical use. The nitrodilators listed above differ in the route of administration, onset of action, and duration of action. Nitroglycerin, which has been used since the 19th century, is commonly used in the treatment of angina because it is very fast-acting, within 2 to 5 minutes, when administered sublingually. Its effect usually wears off within 30 minutes. Therefore, nitroglycerin is particularly useful for preventing or terminating an acute anginal attack. Longer-acting preparations of nitroglycerin, like the transdermal patches, have a longer onset of action, 30 to 60 minutes, but are effective for 12 to 24 hours. Intravenous nitroglycerin is used in the hospital setting for unstable angina and acute heart failure. Isosorbide dinitrate and mononitrate and tetranitrate compounds have a longer onset of action and duration of action than nitroglycerin. This makes these compounds more useful than short-acting nitroglycerin for long-term prophylaxis and management of coronary artery disease. Oral bioavailability of many organic nitrates is low because of first-pass metabolism by the liver. Isosorbide mononitrate, which has nearly 100% bioavailability, is the exception. Therefore, oral administration of these compounds requires much higher doses than sublingual administration, which is not subject to first-pass hepatic metabolism. Tolerance to organic nitrates occur with frequent dosing, which decreases their efficacy. The problem is partially circumvented by using the smallest effective dose of the compound coupled with infrequent or irregular dosing. The mechanism for tolerance is not fully understood, but it may involve depletion of tissue sulfhydryl groups or scavenging of nitric oxide by superoxide anion, and the subsequent production of the peroxynitrite that may inhibit guanylyl cyclase. The metabolites of organic nitrates are biologically active and have longer half-life than the parent compound. Therefore, the metabolites contribute significantly to the therapeutic activity of the compound. Calcium antagonists. Currently approved calcium channel blockers bind to L-type calcium channels located on the vascular smooth muscle, cardiac myocytes, and cardiac nodal tissues. These channels are responsible for regulating the influx of calcium into the muscle cells, which in turn stimulates smooth muscle contraction and cardiac myocyte contraction. In cardiac nodal tissue, L-type calcium channels play an important role in pacemaker currents and in phase zero of the action potentials. Therefore, by blocking calcium entry into the cell, calcium channel blockers cause vascular smooth muscle relaxation or vasodilation, decrease myocardial force generation, negative inotropy, decrease heart rate or negative chronotropy, and decrease conduction velocity within the heart or negative thromotropy, particularly at the atrioventricular node. There are three chemical classes of calcium channel blockers. They differ not only in their basic chemical structure, but also in their relative selectivity toward cardiac versus vascular L-type calcium channels. The most smooth muscle selective class of calcium channel blockers are the dihydropyridines. Because of their high vascular selectivity, these drugs are primarily used to reduce systemic vascular resistance and arterial pressure, and therefore are used to treat hypertension. Extended-release formulations of long-acting compounds are used to treat angina and are particularly effective for vasospastic angina. However, their powerful systemic vasodilator and pressure-lowering effects can lead to reflex cardiac stimulation, which can offset the beneficial effects of afterload reduction on myocardial oxygen demand. Non-dihydropyridines, of which there are only two currently used clinically, comprise the other two classes of CCBs. Verapamil, a phenylalkylamine class, is relatively selective for the myocardium and is less effective as a systemic vasodilator drug. This drug has a very important role in treating angina and arrhythmia. Diltiazem, a benzodiazepine class, is intermediate between verapamil and dihydropyridines in its selectivity for vascular calcium channels. By having both cardiac depressant and vasodilator actions, diltiazem is able to reduce arterial pressure without producing the same degree of reflex cardiac stimulation caused by dihydropyridines. CCBs are used to treat hypertension, angina, and arrhythmia. By causing vascular smooth muscle relaxation, CCBs decrease systemic vascular resistance, which lowers arterial blood pressure. These drugs primarily affect arterial resistance vessels with only minimal effects on venous capacitance vessels. The anti-anginal effects of CCBs are derived from their vasodilator and cardiodepressant actions. Systemic vasodilation reduces arterial pressure, which reduces ventricular afterload, thereby decreasing oxygen demand. The more cardioselective CCBs like verapamil and diltiazem decrease heart rate and contractility, which leads to a reduction in myocardial oxygen demand, which makes them excellent anti-anginal drugs. CCBs can also dilate coronary arteries and prevent or reverse coronary vasospasm, which occurs in Prince metals variant angina, thereby increasing oxygen supply to the myocardium. The antiarrhythmic properties or class 4 antiarrhythmic of the CCBs are related to their ability to decrease the firing rate of aberrant pacemaker sites within the heart, but more importantly are related to their ability to decrease conduction velocity and prolong repolarization, especially at the atrioventricular node. The latter action at the atrioventricular node helps to block re-entry mechanisms, which can cause supraventricular tachycardia. Here are the drugs under the calcium antagonists. Beta blockers. These are medications that decreases myocardial oxygen demand and are known to be effective antihypertensives and antiarrhythmics. They usually reduces mortality and reinfarction in patients post myocardial infarction, and they reduces mortality in heart failure. The mechanism of action of these drugs is through competitive inhibition of effects of neuronally released and circulating catecholamines on beta adrenoreceptors. The common side effects of beta blockers are severe sinus bradycardia and sinus arrest, bronchoconstriction, mental depression or fatigue, sexual dysfunction, masking of hypoglycemia, and with abrupt withdrawal, it may result in increased total ischemic activity, or what we call rebound phenomenon. Listed are the candidates for the use of beta-blocking agents for angina. Here's a table comparing the effects of anti-anginal agents on the indices of myocardial oxygen supply and demand. Currently, we also have other medications which are used for the treatment of angina, and these include the following. The first is nicorandil. It's a nicotinamide ester which dilates coronary and peripheral resistance vessels via the ATP-sensitive potassium channels. We also have trimetazidine, which partially inhibits the fatty acid oxidation that shifts myocardial metabolism to a more oxygen-efficient pathway. And lastly, we also have ranolazine, which is a piperazine derivative approved by the US FDA in 2006. It has an anti-ischemic effect without effects on the heart rate and the blood pressure. The mechanism of action is said to be the reduction of late sodium current that facilitates calcium entry through the sodium-calcium exchanger. And for your reading assignment, kindly read on beta adrenoceptor agonists or beta agonists and their effect as a vasodilating agent.